I think Samira will do the record. There we go.
All right. Thank you. To conduct this meeting wholly electronically and to effectuate both the emergency procedures authorized by FOIA, the CPMT needs to make certain findings and determinations for the record. It is a bit cumbersome as usual, so I ask for your in advance for your patience. First, because each member of the CPMT is participating in this meeting from a separate location, we must verify that a quorum of members is participating and see that each member's voice is clear, audible, and in an appropriate volume for all other members to hear. Accordingly, I'm going to conduct a roll call and ask each CPMT member participating in this meeting to state your name and the location from which you are participating. Please state whether you are joining us from home or agency office. I ask that each of you pay close attention to ensure that you can hear each of your colleagues. Following this roll call, we will vote to establish that every member can hear every other member. CPMT members, Leslie Albatian. No Leslie, wow. I know Dr. Gloria is not here. Stacy Jones Alexander.
Stacy Alexander here in Annandale, Virginia.
Hi, Stacy. Michael Axler.
Mike Axler here in Fairfax, Virginia.
Michael Beckett's. Jacqueline Benson. Michelle Boyd. Deb Evans.
Deb Evans, I'm in Woodbridge office.
Woodbridge. Annie Henderson.
Annie Henderson, Fairfax County Office, Housing.
Joe Clemmer. I could not hear you, Joe. I can see you. I can read your lips. I cannot hear you.
Can you hear me now? Okay. Yeah, I'm here in Fairfax at home.
Hey, Joe. Thanks. Rick, likewise.
I'm here in my office in Fairfax.
Dana Jones.
Here in my office at home.
Rebecca Sharp.
Here in my office in Falls Church.
Dawn Schaefer.
Here at home in Springfield.
Matt Thompson. Lloyd Tucker. Darrell Washington.
Here at home in Centerville.
At this point, I will pass the virtual gavel to the acting vice chairman, Rick, likewise, so I may be heard to make the requisite motion. I move that each member's voice may be adequately heard by each other member of this CPMT.
Please state your name to second the motion.
Annie Henderson.
All those in agreement say aye.
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 Opposed, nay. Motion carries.
Second, having established that each member's voice may be heard by every other member, we must next establish the nature of the emergency that compels these emergency procedures, the fact that we are meeting electronically, what type of electronic communication is being used, and how we have arranged for public access to this meeting. Therefore, I move that the state of emergency in effect for Fairfax County caused by the COVID-19 pandemic makes it unsafe and impractical for this CPMT to physically assemble and unsafe for the public to physically attend any such meeting. And as such, FOIA's usual procedures, which require the physical assembly of this CPMT and the physical presence of the public, cannot be implemented safely or practically. I further move that this CPMT may conduct this meeting electronically through a dedicated audio conferencing line, and the public may access this meeting by calling 571-429-5982, conference code 279-121-98 #. It is so moved.
Please state your name to second the motion.
Matt Thompson, second.
All those in agreement say aye.
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 Opposed, nay. Motion carries.
Finally, it is next required that all the matters addressed today are statutorily required or necessary to continue operations and the discharge of the CPMT's lawful purposes, duties, and responsibilities. It is so moved.
Please state your name to second the motion.
Annie Henderson.
All those in agreement say aye.
Aye.
Opposed, nay. Motion carries. I now return the gavel to our chair, Chris Lem.
Thank you, Rick. We will now begin our agenda items. Next on the agenda is minutes, or first on the agenda is minutes, approving our minutes of October 28th, 2022. Does anybody have any clarifications, edits to said minutes? Hearing none, Janet, we'll consider, go ahead.
Chris, one note is we actually didn't do a vote on the September minutes, so we're going to need to do September and October just to vote on both of those.
We vote on minutes? I didn't know if we voted on minutes.
I think we have to approve them formally.
Interesting. I'm doing all these other meetings wrong then.
Well, it may be me, so we'll check, but we normally do like a vote and then we didn't have that this time for the
Okay,
minutes.
all right.
Sorry about
I
that.
move approval of the September and October CPMT minutes. We have a second? Second from Rick. All those in favor?
Aye.
Aye.
Opposed? That motion carries. All right, on to our items. We'll start with administrative items. Item A1, appointment of FAP representatives. Sarah.
That's me. Good afternoon, everyone. Sarah Young. I'm the Family Assessment and Planning Team Coordinator with CSA, coming before you today to ask for your approval of a new representative from the Department of Family Services to serve as a FAPT member, Jeanette Hopkins. She is a current social services supervisor with PPS and has been working with the county for many years. And she has just jumped right in and has been helping out. She's working primarily with the Tuesday afternoon FAPT, but has subbed on the other FAPT already. She's been a gem, so I'm asking that you support her appointment as a FAPT member. And I just want to say, and I don't know if Michael's here, and it kind of doesn't matter because the person that she's replacing has left the agency, but this all happened while I was out on medical leave. The person, her predecessor, not only resigned her position because she was leaving, she found me a replacement and had everything lined up by the time I got back, which was simply spectacular. So kudos to Nicole O'Connor, who is our former DFS rep. And I ask that you approve the appointment of Jeanette Hopkins as our new DFS, one of our new DFS reps.
Are we voting on this one, Janet?
I think you do have to, is this a vote?
Yes, these
motion.
positions require approval by the CPMT.
Is Jeanette
Motion
here?
to approve?
She is not here.
Not here, okay.
I will share the good news with her later.
I was gonna make her sing a school fight song.
Sure she would.
All right, I heard a motion. Do I hear a second?
Second. Rebecca Sharp.
It's been moved and seconded. All those in favor? Say aye. Aye. Those opposed? That motion carries.
Thank you.
Sarah, you can give Jeanette the good news. And make sure she's prepared to sing a school fight song at the next meeting. Item A2, I'm sorry, I'm amusing myself today. Policy on emergency access to primary substance use disorder treatment services with updated fiscal impact. Janet.
My request is that we're able to do items C1 and C2. There'll be an introduction before we do A2, if that's okay.
I have no objection. Thank you. So we'll move down to contract items. Item C1, out-of-state contract report. Barbara, there's none.
There is no out-of-state contract report at this point.
Okay.
There have been no new requests.
All right. Thank you for that update. Item C2, update on contracts with primary substance use disorder providers. Barbara and Laverne.
Yes, I think that Janet has done a great job letting everyone know about the work that's been going on behind the scenes in trying to support the CSB in addressing the increase in non-fatal opiate overdoses for adolescents and the increased demand for substance use disorder services in the area. And we've found a few providers, but there are none that have a residential treatment program in Northern Virginia. We've located a company called Sandstone that does have outpatient, intensive outpatient in Reston and an array of adult services. For adolescents, they do have a residential treatment program in Crownsville, Maryland, and they also do detox in a facility in Colorado. We don't plan on sending anyone at this moment, but we've been trying to develop the contract details. The CSA management team feels that they are an appropriate vendor, but we wanted to bring this to your attention because the services are much more expensive than any of the other residential services we've ever purchased. The standard Medicaid rate that we negotiate all of our standard residential services is about $460 a day. We're finding, and this is the rates that we're showing you are for Sandstone. I've also been in touch with Hazelton Betty Ford, who we're considering a relationship with, and Newport Healthcare, which has a facility in Connecticut. All of their rates are coming in at about $2,000 a day for residential treatment, where they would be able to provide medication-assisted treatment if necessary, and they can serve this population. Because that is about 400% more than what we normally would pay when we're not able to access Medicaid for these kids, we felt Laverne and Janet and I and the rest of the team and the CSA management team wanted to make sure that you guys were aware of the situation, because the potential impact for serving one youth just for the initial 30 days of RTC and then partial would be provided in a residential setting also. And then stepping down to intensive outpatient, you're looking at about $120,000 for a course of treatment for a youth, and that's barely 4 months of service. When these contracts are accessed, they will be, if my team receives a request to use any of these providers, we will be bringing them forward to you so that you're aware of them through the monthly out-of-state placement or out-of-state child-specific contract report.
One of the reasons Barbara and I are asking for this consideration and Janet is asking for this consideration is because the CSB has been managing multiple calls for youth with non-fatal overdoses weekly. And we have been able to find very few resources within the local area or even nationally to assist us with responding to these youth needs, having some place that we can refer them to where they can receive the proper care, etc. So I just want to highlight that because not only are we not finding plethora of places for these youth to be treated, when we do find these when we do find places for them to be treated, there is often no funding source or they accept Medicaid or they accept insurance, but we have to fly them out of state for those resources that do accept the Medicaid or insurance. And a lot of and many of these youth are undocumented. So flying them out of state becomes a problem. So just wanted to share that piece. And we also, as Barbara shared, we've interviewed so many places over the last couple of months. And in interviewing them, we get to the point of a contract or having a contract, and there is often something else that needs to be done. So when we are able to find resources, we are really trying to make sure that we have permission to spend the funds needed to send the youth or refer the youth to these resources. Thank you.
This item is more informational. The CSA management team does have the ability to approve the contract. However, as the other speakers stated, the rates are so high that we felt we really needed to bring that to you. And the next item, A2, is an opportunity for us to look at the impact or how we would go about using these providers. So we felt like this item gives you the information that this provider has these rates, but other providers that we're looking at that offer the treatment that we don't have, that we need, are coming in at similar, very high rates.
So Janet, thank you, and Laverne and Barbara, thank you. But so I'm having trouble really visualizing this. So these are services that we're having trouble finding, and we found them, but they're high rates. But they're high rates compared to what if we don't currently have the services available? So I'm trying to figure out a delta, because whenever you start talking about higher rates than what we've maybe seen, generally there's a delta, but it's hard to have a delta if we don't currently have services available. So can you help me with that a little bit? I'm trying to figure out what the totality of the financial impact will be.
So what Barbara said is, we're used to paying somewhere in the $400 a day for residential, $600 a day. Acute psychiatric will be about $800 a day. So when you look at $2,000 a day, you're looking at more than double. So it is twice as much as anything else we've purchased in CSA. And Barbara, if you can correct me if my figures are wrong, but just to give you that ballpark delta, it's twice as much. This doesn't exist anywhere else. And this appears to be the market for this service. Detoxification, inpatient, medically supervised for 30 days, followed by the child being there for about 30 days in the kind of more of a residential. It's roughly that same rate. So we're, again, we really felt like this is a very important issue. Our community is very concerned. We don't have anywhere else to go, but it's high, and we want you all to know that.
I definitely get the urgency that, we don't have anywhere else to go. I'm just trying to put in perspective, like what the jump will be. So what is our normal, not normal, but what is our regular expected expenses around this type of service with the lower rates, and then putting that on to these higher rates, understanding that the need for these services is expanding. I get all that. I'm just trying to figure out, maybe we can't come up with a delta here, but generally when you're talking about cost increases, you want to at least know the totality of what that delta increase would be, but maybe that's not available in this case.
We've not had many contracts for substance use disorder or as a primary presenting issue. There's some co-occurring disorder programs. Timber Ridge out in Winchester does have an ASAM 3.5 residential program for adolescent males, and they do accept Medicaid. So we're looking, the programs that we have found don't accept Medicaid, and they will not accept Medicaid. So in trying to come up with a delta, it is going to take a little bit of work, because it's more of an uncharted territory, because we're talking with providers that we've actually not wanted to work with in the past because they don't take Medicaid and they don't have a more friendly government rate. Newport Healthcare does have some group homes in Northern Virginia, but they don't serve the substance using kids here in Northern Virginia, and their daily rate for their group homes is about $2,000. It's across their system. It's not just for the co-occurring disorder program in Connecticut. Does that help answer the question a little?
Yeah, a little bit. I mean, it's really hard to pinpoint, you know, the total impact. We know it's going to be a lot, but we also know it's needed. So I don't really feel like we have a choice. But it's just trying to figure out if we could project what this means in terms of committing to this, what that means. And again, I obviously I don't believe we have a choice. We need to commit, but
Chris,
anyway.
I
I
in
think, Chris,
item eight-
to try to put this in perspective, so that, when someone comes in to the CSB for an assessment, we'll assess for the level of care. And we use the American Society of Addictive Medicine to be able to do that. And these levels of care are based upon that. And, a big percentage of the kids don't need these super high levels of care that are super expensive, but the kids that do need it are the ones that are at the highest risk of having a significant negative outcome if we don't intervene with them and get them into that level of care. And, we don't have this now. We might have the potential to buy it or build it with opioid abatement money, and we kind of have some things going on behind the scenes for that, for more of a longer range plan, if you will. To put things in perspective, we directly operate these levels of care with adults here at the CSB, and the bed day cost is right around $900 a day. So that's kind of the comparison in the adult world. That being said, the Medicaid reimbursement rate for this level of care in Virginia is just over $400. So it doesn't come anywhere close to touching the true cost of care if you're looking at Medicaid reimbursement for these levels of care.
And Chris, also to add, this week was an unusual week because we did have 4 kids who met the criteria for this level of care, 2 of which we really went round and round trying to place.
No, thank you, Laverne. That's putting it into some real context that these needs are here now. There's an urgency of this.
And this, unfortunately, this isn't going to remove all the barriers to getting these kids the services, because we have found that even though these providers are able to serve adolescents, they don't have all of the language capability that our population is presenting with.
Okay, Janet, did you want to flow back into A2 now, or do we don't need a vote on this?
No, we don't. And I think, I don't know if A2 will help a little bit, but A2 is very much related. So C2 is really just describing for you what we're finding out there. And we do have a partnership where we're all working together to identify providers around the nation. We've looked in state and we're looking at surrounding jurisdictions. And then we've looked across the nation to try to identify programs that would fill the gap. Because right now, before we're able to build programs, we're going to probably end up buying. And what we're finding are these very high rates. So as Daryl was talking about, opioid abatement money might be available for the building, but that will take some period of time. And so the urgent need now, as Laverne has noted, is these children are being identified right now. So item A2 is really what CSA's response is. And this is something that you all have heard before, and you voted on it in the September 23rd meeting. And we're actually bringing it back to you because of the rates that we're finding. Our original estimate was that it would be roughly $45,000 to do 60 days of treatment, just that emergency 60 days, and then the rest of the treatment would flow from there. But we're identifying that it's more than that. So 45,000 was a rough estimate before we actually had any firm rates from providers. And now that we have the firm rates, we are looking at over $100,000. We're looking at possibly $115,000 to $120,000 for those initial 60 days. And that's not the end of treatment. That's just those initial days. So I wanted to walk through a little bit of what it is that we had you all approve, the process, and highlight, the pros and cons of how we're approaching this, mostly because I think it's really important when we're spending this amount of money that you all are very aware and that we've answered any questions that you have about internal control or budget or money. And so again, I'm just trying to do this transparently with you so that you're aware of what our process is and can guide us if you are not in agreement or don't support how we're doing it. So the way our process works, as we presented to you in the past, it's we would be offering intensive substance use disorder interventions and related support. So we are able to approve a package that a case manager could access on behalf of a family and child for 60 days. And it's an array of services that include inpatient detoxification, residential substance use treatment, partial hospitalization, intensive outpatient, and supports like transportation, language, pharmacy. We really don't know exactly what kids will need, but if they don't have insurance and they don't have Medicaid and they have no way to pay for any of this, the provider is going to want to know that we're willing to pay. So it's a package that would allow us to get these kids immediate access to care. And the way we go about doing that is we don't have our usual team-based planning meeting, or we don't have, 2 to 3 weeks before we get to the FAPT. We do an emergency expedited process where the case manager prepares a document, a form. It would be mostly the CSB that we're looking at who is the lead on this. They are aware of the children. They would be determining this is a child who needs the highest level. They need emergency access because they could potentially have a fatal overdose, and they would be bringing these cases forward. It is heard at the FAPT briefly. This is not a full FAPT meeting. It is a brief review, just like we do with Leland. And our CSB is presenting the need, and the FAPT then approves the 60 days. We are assuming that many of these children will be using substances in ways that are very harmful to them. I am assuming that most of these children will be mandated using the CHINS criteria. They are a danger to themselves because they could die from fentanyl at any point in this based on their pattern of substance use. And that is the assessment that we're relying on the CSB for as the lead agency bringing these cases forward. We would have to make sure that the family completes the consent to exchange information. There's a CANS, and that form is put forward. And then we would be using our contracted providers to get that child connected to the appropriate provider. Right now, it's Sandstone. We don't have any other providers under contract who can do the detox and the residential primary substance use treatment. We do have the lower levels. We have PHP, we have IOP, we have the Timber Ridge program, as Laverne mentioned, but we don't have those other ones. They don't exist here in the Commonwealth. And so our original ask to you all was that we estimated it would be about 45,000. That's not true. It's over 100,000. And from a fiscal analysis standpoint, we're looking at 1,520. I can't know for sure because it's a package. We don't know if the kid needs pharmacy and transportation. We don't know. But that is the ask to you. And so I'm going to keep on going here. Internal control. I just want you all to understand this, is that when we place a child emergently, it's done without some of our usual processes. CSA takes a little time. We have UR, we have a full FAPT meeting, we do some things that take a little bit of time. And this would be expediting and moving these children into services quickly. So that means we're relaxing some of those internal controls, and we are relying on the CSB to ascertain who needs it and ascertaining the ASEM level and telling us this child is at risk of serious harm to themselves And so the FAPT would then hear it briefly, approve it, and then any remaining services would be going through the usual process. So the reason I'm bringing you this item again is I'm asking you, are you approving for us to move forward with, given the new rate, do you want us to continue with this expedited kind of emergency access? We don't know how many children, Laverne's got about 4 waiting in the wings where we still can't find a provider for all of them. And I'll stop now to just see if there's questions, comments, concerns, so that we're doing the right thing, but we're also, doing the right thing administratively and budgetarily as well.
Hey, Janet, this is Matt.
Yes.
Sorry, I forgot to raise my hand. I mean, these cases are expedited cases, meaning that time is of the essence, that you don't have the luxury of waiting to bring a case back to a CPMT, for example, that the need is imminent and that you need to place them. And so it sounds like you need the ability to do that. Is that correct?
That is
Yes.
our understanding, and Laverne is
Yes, that is
here.
correct, ma'am. Sorry, Jane, that is correct, ma'am. Many times these kids are in need of immediate detoxification services, and getting them into services, there is a timeline by which we need to treat them in a medication assisted treatment placement at the level of care, i.e. detoxification or residential, as needed as quickly as possible. And understanding that oftentimes coming back to CPMT could be weeks, that's not going to serve these youth's needs.
Our budget analyst is on the call, so if we want to just check in with them that we have the budget authority, we do have a budget report coming. If we need to check in with them as to whether or not CSA has the ability to cover this, we can ask either Desiree Roberts or Tim Seltzer.
Janet, I think some of this is going to depend on kind of what we see the need to be. I think right now it's a little early. It seems like we have a few kids this week. Whether or not we could place them or not, it's kind of to be determined, right? Based on our conversation that we had on Monday. And so I think that there would be some capacity, maybe up to about 10 kids or so within some of this existing CSA. But beyond that, we would need to kind of look and see what our long-term approach would be. I think this depends if this is going to be a permanent change moving forward. I think in the short term, if there's like an immediate need, we have some readily available funding that can kind of subsidize that. But I think we need to do a little bit of a deeper dive with the projected number of youth we would need to serve, and kind of then do some longer term for sustainability. I would imagine we wouldn't want to start a program and then find out that, oh my God, we have 50 kids that need this and we don't have that built into the budget. And so I don't know with this step, if there would be parameters around the number of kids, would it be like as is? And I don't know if, maybe that's not fair, right? Like first come, first serve, and we can help this number of kids, like youth per year. But I think we would have to probably have some parameters. I don't think it would be an infinite at $100,000 a pop. It would not be an infinite pool, right? And so, maybe more on the programmatic side of how would we kind of refine that and decide who's most deserving of that. Because I don't think we have capacity to maybe meet the demand if we had 4 calls this week. I think some of it will also depend on provider capacity, right? I think this is not something we've seen come to fruition. So if we have 4 or 5 kids in a week, how many could providers realistically accept? And then, when would we go from there? So I think we'd have to do a deeper analysis on the number of youth we'd want to serve, and, maybe not narrowing sounds wrong, but parameters so that it stays within something that we can sustain long term.
One of the things that helps sustainability, Desiree, right now we're looking at the most acute youth in need, 3.7 level of care, detoxification. And we're prioritizing based on what's available at, or what youth are in need at the time. So, the youth that need 3.7 definitely go forward first. Then we're going from there. We are also standing up as quickly as possible in the CSB and other IOP program. So we are working on that as well. So we're working on outside things to help support this need. And then there is going to come some times when IOP is just not enough for many of these youth. I've already been in contact with Rick, and he and I have already been in contact with many other providers in the communities. Rick has IOP. If I have someone who needs IOP right now, I can pick up the phone and I can call Anova. I can call Rick's team, see what bed space they may have available at the time. So it's not only having the level of services that are in need in place, but it's also making sure that those level of services meet the needs of the youth that are showing up at the moment that they're coming. What are their needs? Those youth that came last week didn't need IOP. They clearly needed detoxification and residential services. So it is a mixed bag, but we are putting together everything we can to make sure that we're serving as many youth as we can at the many different levels of care at the most inexpensive rates. But this is truly what we have right now.
Okay. Janet? What are
So-
we looking for moving forward?
So I think this is a policy and a practice that you all approved in September. I'm coming to you to update you as to the expense. We bring you budget reports. We would also be, because these are out-of-state programs, right now, we would be bringing you updates, and we can continue to update you on this so that, with Desiree's comments in mind, this is not, we have to be mindful of the number of children we can serve. But I wanted to formally ask you all for your approval to continue. We have not done it yet. We've been trying to do it, but we have not been able to pull a package. We haven't been able to implement this yet because we can't get a provider to accept the children. And when we did get the provider and we found the rates, we were like, wow, this is big. So I'm asking you whether or not you approve for us to continue on with this process so that we can respond with urgency to meet the needs of these children, knowing that we will obviously be bringing this back to you and keeping you updated on our utilization, the costs, and asking for changes or revisions, modifications as needed based on what we find.
So in lieu of further questions, which we can still take, I do need a motion essentially to reaffirm our approval of access to these primary services on the emergency basis. Is that right?
So moved.
I have a motion. Do I have a second? We have multiple seconds. Okay, we have a motion and a second. All those indicating approval, say aye.
Aye.
Aye. Any opposed? That motion carries. All right, Janet. Yeah, well, I think this is something that we need to highlight. So as we go down and as we start including it as part of our regular updates, I'd almost like to see it be kind of highlighted specially so we can make sure that we're tracking that given the significant rates. So if that's okay, thank you. I see you're nodding your head. Thank you.
We will absolutely do that. Thank you.
Okay, we'll move down to information items. Budget report, Desiree.
Hello.
Hello.
For those of you I have not met, I'm Desiree Roberts. I am just a few months into my role as budget manager. On our team, we also have Sandra, who will be supporting CSA. And from now on, she just started this week on our team, so she's also on the call. So I wanted to let people know that's why she is here. So I'll go over the October data. So for program year 2023 through October 2022, we have expended $4 million of the pooled expenditures, and that is for 604 youth. This time last year, we serviced 643 youth at 5.5 million. So our costs are down about 1.5 million or 27%. Though it's about only 6% less clients, our costs are still down cumulatively 27%. Going down to our chart, you'll see program year 2022 on the left-hand side, and then 2023 for residential treatment and education. Our 23 expenditures are up 147,000. For private day special education, our costs are down 1.6 million. And some of that is the difference in youth serves. Last year, around this time or in December, we had 247 youth versus 229 youth now. We had a few students who were getting either one-on-one or two-on-one kind of services that this year I think we're not necessarily, or doesn't seem that we're doing that. And then there's a few of our schools that cost a bit more for the private day education that are currently not accepting students, driving some of the costs down. And we'll continue to kind of watch out for those numbers and driving factors over the coming months. And non-residential foster home, our expenditures are up $193,000 through the end of October, or 17% increase in cost. In community services, our expenditures are down about 297,000. And non-mandated services, our costs are just slightly up, $33,000. And then our recoveries, which makes sense since we have less expenditures, our recoveries is down about $100,000. And the residential treatment and education, we've serviced 27 youth and 23, so 6 less youth served than last year. And private day special education, we've serviced 67 less youth, so 146 versus 213 last time this year. Non-residential foster home, we are relatively level, just 4 additional youth, but pretty flat there. Community services, 310 youth served, so that's 64 less youth versus the same period last year. And in non-mandated, we've seen an increase of 36 youth, so 99 thus far. So overall, in our unduplicated count, 643 youths were served last year versus 604 this year. And so in the residential treatment and education, we already kind of went over the amount that it's down, or the amount that it's up rather. But the cost per youth seems to be up, and the primary driver seems to be in the residential Medicaid and the education sector for residential Medicaid and non-Medicaid placements. Those costs are really what's driving it. The rest is relatively flat. And then in private day special education, our costs are down 1.7 if you round up, with 67 fewer youth. So the cost per youth is at about $4,000 lower than it was this time last year. Non-residential home has increased by 194,000 with 4 fewer youth. And our community services is down 297,000 with 64 less youth served. And the average cost per youth decreased by 24%. And the next page is really similar data, just kind of displayed out. So I guess big numbers I would point to is our Our grand total with the unduplicated for both our mandated and non-mandated services is just over $4.3 million. And that's like for this period versus last year. And then our recoveries is 276,000. So our total net cost like to date is $4,058,909 for 604 youth. And the average cost per youth, you will see is down for all total expenditures, $8,642 last year versus $6,720 this year. And then in residential unduplicated, our cost per youth is up about $8,000 per youth to $26,547, and non-residential costs and the community service costs per youth are both down year to date. And I would say those are really like the highlights. If anyone has any questions, I will do my best to answer. I've been in CSA for all of 3 weeks, but we pulled the data together and have tried to make as much sense as we could of the Harmony data and asking follow-up questions as needed with program managers to walk us through why we're seeing some of those changes.
Thank you, Desiree, and welcome. Does anybody have any questions? Okay, seeing and hearing none, we'll move on to the next item. Again, thanks, Desiree, and welcome. Item I2, update on state work group recommendations for special education funding. Michael and Janet.
I'll go ahead and get us started. And Michael has been on the state work group. And for about 2 years now, the state has convened work groups to look at a recommendation by JLARC. JLARC recommended that they consider whether special education services like private day and residential for the IEP move out of CSA and move over to VDOE. And so the work group has met and they have finally produced their report. We did discuss it at our last meeting and went over our understanding of what those recommendations are. Now we have them in writing. The part that I just wanted to kind of state for everybody is the recommendations, and you do have a copy of it so you can read and see all the nuance of it. But there's a summary here of what some of those recommendations are. And so I'll just note those. The work group did recommend the transfer, but if you look at the actual document, what people paid attention to is the voting, and that there were quite a number of people who abstained or were not present to vote. So there really wasn't a strong consensus by the participants to move the money. And then there was more consensus on some of the other items to continue the wraparound special education funds that allow you to provide home and community services to children with special ed eligibility. We do, in the budget report, there's a line item that shows you how much we spend. It asked noted in recommendation 2.1 that they wanted to continue the current structure, which does not allow CSA funding to purchase services within a public school, with the exception of in the last year, we've had transition services. So if a kid is coming back from public day or private day, for 12 months, CSA can buy some services in the public school to support that child. They don't really want CSA to be used because it seems like to people it would be supplanting a public school obligation for services in the school. Something new that came out of the group was recommendation 2.2, creating a new funding pool to support youth in the least restrictive setting in the public school. These would be funds that are probably going to be housed with the regional, it's called CISNA. I'm not really sure what that stands for, but it's a regional funding. So some of the localities have come together to create regional special ed programming. And that is in the VDOE has that money. They're thinking about asking for a pool of money that school systems could access to keep kids in the public school. Let's see, the next one was, again, supporting the transition services to bring kids back. And then they did, consider, should CSA be buying other kinds of services? And it was kind of confirmed that whatever's in the IEP should be determined by the IEP committee, just like we're doing now. So these were the recommendations in the report. And the new piece that came out was there was a cover letter provided by the Secretary of Health and Human Resources, I believe, Secretary Littell, who said the Secretary's letter, the statement was, given the lack of a strong consensus that a transfer to VDOE would improve administration or outcomes or reduce costs, the administration does not recommend a transfer to VDOE at this time. So the Secretary's cover letter signaled where the administration is going with this particular action at this time. So I just wanted to, it's not clear to me what will happen next with this information. The other thing that I will bring to your attention is another issue related to this is the state is continuing to, in the Code of Virginia, the Appropriations Act is a rate setting methodology. So that is in the code for them to implement that as of July 1, 2023, whatever next year is. And that rate setting is planning on moving forward, but we do not have a fiscal analysis. So those two things have been going on simultaneously, and we did get an answer somewhat on this VDOE issue.
Any questions, Janet? I know this was big, and you and Michael did a great job of keeping track of everything, all the moving parts, and I know it had the attention of some of our board members. So, does anybody have any questions or comments?
I will let you all know that some of the data in the report is very interesting, and it really does highlight some of the trends. So if you have an opportunity to read and take a look at some of the data charts, it's helpful, it's interesting.
Okay. Seeing no further questions or comments, we'll move on to item I3, our FAP report on residential utilization. Sarah, G.
Good afternoon again. For us to get to the report. So many pretty colors in that one. Let's see.
A lot of pages. Let me get there.
I could sing my school fight song in the meantime, if that's what you want to hear.
Oops, there we are. Here we go.
All right, there we go. Okay. Oh, actually, I think it starts with Jean. So here I am. Maybe I should make Jean sing. Go ahead, Jean.
No songs for me. You don't want to hear me sing. All right, so not much to report for residential for this quarter. I will just say that we had 6 children who entered long-term residential for the first quarter of this FY23. And I will also let you know that one of our youth transferred, so they're not included in these numbers. And I will just say that out of all of this data, what I found most salient was that for the ages and for the agencies who are referring, it pretty much is the same as it always is. But what really stood out was that the gender for the first time was quite different than we usually see. There was 1 male and 5 females. So 5 times more females entered residential than males. We usually see them to be about equal. Sometimes there's a few more males than females, but it just really stood out that we had such a huge gender gap this time. And that was really what came across the most. And that's really all I have to report for that. Sarah, you're up.
Okay. Samira, if you want to, I think it's Samira, scroll down. There I am. Okay. For the first quarter of FY23, we had 31 FAPT meetings. You can see there There was a slightly higher amount from the CSB than foster care, and juvenile court always likes to weigh in with a request or two, and that they did. Almost perfectly split between requests for new placements and requests to extend existing placements. Most of the requests for initial placements were supported. We only had 2 where they had plans, community-based service plans developed in lieu of a plan supporting placement. One number, and those numbers are all pretty standard. One of the numbers that's jumped a little bit this quarter is the number of youth that were actively receiving ICC at the time of coming to FAPT. That's typically in the 20 to 30% range, and so it's jumped up to just below 50%, which is a little high, so we'll keep an eye on that. We also had 4 youth that were placed prior to coming to FAPT. 2 had been placed by their parents and 2 were placed by foster care. I left that sentence off. And there were no appeals during this quarter. Scrolling down, that's just more of that. The last chart is actually somehow got a little wonky. Samira, if you can go a few pages down, it got attached to the end of the SIR report because we just wanted to see who was paying attention today. So congrats to those who noticed that it's not there. Keep going, and there it is. This is kind of interesting, which is why I didn't want to leave it out, even though it got a little misplaced. This is an average of the monthly FAPT meetings held, and looking, back over the last few fiscal years, you'll notice it's drastically lower. It's, almost half in some instances, and we've really been trying to figure out what that is. Some of it is, our overall volume is down across the board in CSA since COVID. I think some of it is we've seen an increase in our evidence-based services that are available, MST, FFT. They're now directly accessible via Medicaid. Folks don't even have to come through CSA. We have been filling up ICC, and so I think all of that may come into play with it. I think also because this is just number of meetings and it's not necessarily initial versus extension, I think we are working to get youth home more quickly, and so they're not coming back for perhaps as many extension requests as maybe they were a few years ago. So all positive signs, with the exception of that lack of volume overall. If we're not catching some of the kids that we really would like to be catching, that would be the only thing that would, I think, make this sort of a negative indicator as opposed to a stronger or positive indicator. But that's it with our FAPT report. Samira, you can go back up. Sorry about the little wonky chart misplacement. Are there any questions?
Okay, thank you.
Thank you. I'll hand it back to Jean.
Oh, well, I'll hand it back to Chris to introduce the next item.
Okay. The next item will be the serious incident report. Back to you, Jean.
Thanks.
We're playing pickleball now.
Yes.
Back to you, Jean. Back to me.
All right, Samira, if you don't mind just going down to the next page. All right, so our serious incidents, will start with our provider monitoring. We did have one provider this first quarter of FY23 who we needed to reach out with and have a conversation in regards to the types of service that was being provided. It came to our attention after we learned that we were billed for services that had not been provided to a client. We have talked with them and they are in the process of reimbursing us for that time that we identified. But throughout that process, we also learned about some clinical and ethical concerns that came to us, as well as some we had some difficulty with communication and lack of being able to respond. And so we are addressing all of those. All of those things were taken to the CSA management team. It was recommended that the provider be moved to a tier 2 status and require a child-specific contract. And so that is now in place right now and being monitored. So we're just making you aware of that. As far as our SIRs, we realize that this has not been brought to your attention for a while. So I will do my best to kind of get you up to speed. So for our first quarter of fiscal year 23, we had 162 reported serious incident reports. And you can see here, like that with the averages. So in 2021, it was down to 146, and then it definitely had an increase with fiscal year 2022. We believe that a lot of this is due to the fact that kids are now back in school and we are having kids be able to be in person. And so we're seeing that increase. So we'll continue to monitor that and hope that that is all that's causing that difference. But again, that is still to be seen. So as we go down, we're still seeing the same types of numbers. The number one reason for serious incidents is for physical aggression. Usually it's peer-to-peer, but every once in a while it is with a staff, as you can see in the writing. The restraints that I'll talk about in a second are all physical aggression against a person. And then our second biggest reason for reports is self-injury and then runaway. And runaway is, we have to use the word runaway for the state, but sometimes it's an elopement. So they might have just kind of run down the street and then kind of stood on the corner until somebody went and got them. So not a true runaway. So then if you go further down in the report, as I said, you can see that we had, oh, Samira, do you mind moving it down to our restraints graph? So we've had 15 restraints total for the first quarter in the fiscal year. And 3 of them also included seclusion. We will be bringing you, as we go forward, the averages of this against the other fiscal years. It came to our attention just recently that we had not gotten all of our, one of our providers had not provided some serious incident reports that we needed to include in this data before we could get you the averages. So just be on the lookout for that in our next report when we report out to you for fiscal year 2. Are there any questions?
And I'm sorry, Jean, thank you. Sorry, this is Lisa Morton. I'm with the Children's Services Act as well. And I'm going to have the opportunity to working with this going forward. Can you hear me okay? Chris, you look like, sorry.
Yeah. Yes, we can hear you.
Thanks, Jean, for bringing that up too, because just so you all know that the numbers may change a little bit as we go forward, because sometimes we do get reports a little later. So sometimes, just so you know that, let's say we don't, the number is not quite the same. We may get reports a little bit later. And so we'll update those and keep you all apprised of that. Thank you.
I'm sorry, and you may have gone over this, I just didn't hear it, but so the serious incident reports in the one chart says 162 for quarter 1 and says 134 in the next chart, or it says 134. Did you address the difference in those two numbers?
Thank you. Yeah, that's part of why. Yeah. So literally we're working on a daily basis. So I think within a couple of days or two, there were ones that came in that were updated because we may get them. I mean, typically they come in pretty regularly, and we're working with relations and providers to make sure that we're getting them on a timely basis. But sometimes it may be delayed. And so that's where the discrepancy is right here, as far as the 162 compared to the 134.
So the 162, we know there's 162. We just don't have the level of specifics. We only have the level of specifics right now of the 134, but at some point we will have the specifics for all 162.
Correct. Yes. And it is evolving. So Chris, I thank you for bringing that up, because that's something we continue to work on with providers on getting them in a timely basis. Typically we get them within a day or two. There are some that we get after 30 days. So we update them as we get them. And so Jean and I were working on this together, and within a day or two, that diversity came about. So thanks for asking.
Okay, does anybody have any questions or thoughts on this data? Seeing and hearing none, we'll move on to Item I5, parent contribution credit card service fee. Who wants to take that one?
Hi, this is Janet again. This is an item I wanted to just raise your awareness to. It's part of our ongoing work in the program has been addressing the parental contribution requirement for CSA. And we've been, over the last many years, trying to just improve our process. And one of the things we've been doing is working on collections. So we have been referring families to DTA as based on our policy when people are overdue in making their payments. One of the other things that our parents, when they were talking to them, have requested the ability to pay using a credit card. So for many years now, what people are doing is they have to do a check or a money order. And I'm being joined by Alicia Galogli, who is with DFS Budget Fiscal. And together we've been all working on kind of improving our process, making sure we've notified parents, giving them opportunities to work with DTA to do a payment plan. And one of the other areas that would be more family friendly is if we were able to offer a way for them to pay using a credit card. We were in the process of setting this up, we were asked, if parents want to use their medical flexible spending account, which parents want to do, there's the question of how the credit card processing fee will be paid. So this is what I'm bringing just to, raise your awareness. We're trying to make some decisions around this, is that the service charge for using a credit card would be 2.35%. And the question is whether or not the family would be the one responsible for paying that service charge for the convenience of using a credit card, or whether those fees would be absorbed by, it would have to be the CSA program's administrative budget. If we were to absorb this, the families would be able to use their flexible medical spending account credit cards. If it's passed on to the parents, the way it gets set up and coded, they can't use their card. So what we're working on right now is looking at how much that would cost us and what that might look like from the parent's point of view. Attached to this document is a chart showing you all the amount of money that we typically have been collecting each year for our parental contributions. And you can see that it's ranged to a high of $314,000 to last year, $192,000. And so that average over the past 5 years is $238,000. So if we were to pay the service fee, it would cost us $5,600. So just based on the average, that means if every single parent used a credit card, the maximum amount based on the averages would be that $5,600. So we're in the process of just trying to sort through what people's desire is in terms of whether it's appropriate for it to be a service fee passed on to families or a service fee that we cover in our program. And I don't know, Alicia, if you have any other things that you'd like to add about what other programs do, or how we would model ourselves off of other programming.
Yeah, and excuse my scratchy voice. I'm still recovering from a cold. We have a credit card portal that we use for the ADAPT anger management program currently. So this would mimic that, where there's a payment landing page on the county public website where parents can go or guardians can go to make their payments. Our staff wouldn't be involved. We'd definitely direct them to that page where they could make payment. It should be pretty straightforward. They will get their bill in the mail and have the information, fill it out online and press pay. We've been hearing a lot from our clients that they want to pay via credit card or debit card. It's a lot easier for them. A lot of people don't have checks anymore. And other localities do accept credit card for other things. So Definitely, we've been feeling kind of the pressure to meet this need from our clients. So, looking into this and hoping to get this implemented in the next few months here to help our clients out. I can definitely send a link to the Adapt landing page where you can see what it looks like if you guys are curious. But yeah, I think it's going to be, if you guys agree to it, I think it's going to be a really good tool for our clients and hopefully actually get some addition, have more parents pay or more clients pay, because we definitely have seen that a lot of people either get the bill and don't pay or don't feel like they can pay or want to pay via credit card because they don't have the cash right now and can't cut a check. But, unfortunately, we can't accept the credit card payment. So then they're stuck between a rock and a hard place.
So the adapt fee, who's paying the 2.35%?
For Adapt, DSVS is paying the fee. So they don't push the fee onto the Adapt clients. And that I don't know the full details of that, but I know some of them are court mandated. So the court may not allow them to push the fee on top of the training onto the individuals.
So Janet, before we open it up to questions, I've got a lot of questions, but they're not for here. They're more for internal, to talk to finance and DIT. So, I'm not sure where to go with that. I definitely think we should be doing this and making it more user-friendly to our parents, to our families. But yeah, I'm not sure this 2.35. So, but let's open it up for questions. Joe, I see you. We got your hand up. Uh-oh.
Sorry about the jet airliner taking off in the background. I hope you guys can hear me. Janet, did I hear you say that if we push the fee to the parents, they can't pay? Something like that.
Yeah. So if somebody has a a flexible medical spending account with the credit card and they want to put it on the credit card, you can't put a service fee, it's not allowed to add it to the service fee. So, I mean, theoretically, I guess somebody could pay with a check and then ask, and then get reimbursed through their medical spending account, but they couldn't use their credit card in the portal that we want to set up. So that was really the only reason why I'm bringing the question forward. Should we be paying this out of program support funds? So, I'm just trying to get some information and feedback from you all about whether that's appropriate or not, or whether the fee should be borne by the family and then the medical spending account is not our problem. They have to use a check.
My 0.02 cents. If this amount can be covered without causing any type of difficulties, I would be 100% for it because anything to get more help to the families. So that's where I'm at.
Thank you, Joe. Michael.
Good afternoon, everybody. Sorry, I'm a little tardy. Janet, thanks for the presentation. And Chris, to your point, Janet and I were talking about this earlier today before CPMT, and I said there are going to be lots of questions, right? And I think in terms of exactly how the underlying sort of business process and sort of some fiscal questions, and I think just to sort of in support of Janet, I think this is a good idea. But I also think that this right now, what we're doing is creating situational awareness and really wanting to sort of bring a more full sort of explanation back to CPMT once sort of questions are answered, so that we can really see through the lens of developing a policy, what are the stepwise sort of components of this to make sure that we have sort of clearly identified sort of how this works out. And I think, to the point that a lot of families have flexible spending accounts, and because of the current structure, they're not able to use that. I think that's a deterrent, and it could unnecessarily send people into collections when they actually do have some resource to offset sort of a direct expense.
I will say that they can use the flexible spending account. It's just more cumbersome. For right now, somebody could pay via credit, if we had a credit card that couldn't accept flexible spending debit cards, they could pay via their own credit card, take that receipt and submit it to their flexible spending account to get reimbursed, just like they could if they wrote a check to us to get a receipt and then submit it to their flexible spending account. But as you all know, if dealing with your own insurance, when you pay out of pocket and you send it to them to get reimbursed, you never know how long that process is going to take and when your money's going to get back. I will say that those flexible spending accounts are a lot quicker than my health insurance, but still it is a bit more cumbersome than just swiping your FSA card, just like a debit card. So just clarifying that one.
Thank you. Any other questions? Janet, I think I'm where Michael is. Let's take this back and maybe bring it back to the next meeting. I think most of us are where Joe is. Whatever we can do to make it more, again, helping the families in whatever way we can. And if this is adding another option for the families, great. We want to get there. I definitely don't want to push any money towards the families, onto the families. But I still have some other internal questions that I want to focus in on. So maybe we can bring that back to the January meeting.
Sure. And we did bring it as an information item, as Michael was saying, to just raise awareness, get some feedback about, what the CPMT's thoughts are on this and surface any questions so that we can respond to that before it becomes a votable item.
Excellent. Mike, you got another question or you never took your hand down?
Sorry, let me take that down.
Look, you come late, you leave your hand up. Come on, man, you're slacking.
How do I do this? Oh, there we go.
All right. Seeing no other questions, let's go down to Novico, our private provider items. Do we have anything?
No, our meeting was canceled this month, so I have nothing to bring forward.
Thank you. Our parent representatives, do we have anything for our parent reps? I don't see any hands.
I have nothing to report.
Thank you. Thank you. How about our cities? We'll start. We know Leslie's not here. How about Falls Church?
Hello, everyone. The only thing I have to report is that we had the meeting with Chris to talk about the opioid abatement fund and how we plan to make use of the funds. And we kind of have no idea right now. We're kind of meeting with all the parties, schools, and that kind of thing to determine what would be the best use of the funds. So that's the main thing that I have to report. Oh, and then also we have come up with a solution for our Marcus Alert, where we're going to be using our mental health clinician for Aurora House for our group home is going to be doing some hours with Falls Church PD, advising officers that are CIT trained. And then she's also going to be doing some ride-alongs and virtual support whenever they encounter, residents with mental health needs. So we feel pretty good about that. And they're going to cover her hours for that. So those are the two things that I was going to report.
Thank you. Yeah, the opioid abatement, for those of us that were around when the tobacco settlement monies started flowing in, it has that feel, but this is much, much, much bigger. And certainly they're needed funds, and they're going to be used. So, but it's a lot to be able to make sure we're setting up the administrative structure to be able to best use those funds. So thank you. Janet, do we have anybody here for public comment?
No.
Okay. So it is 2:22. I will entertain a motion to adjourn.
Mayor Washington, so moved.
Second, Michael Beckett's.
Been moved and seconded. All those in favor say aye.
Aye.
Okay. Those opposed, stay muted. No, I'm just kidding. Those opposed. All right, everybody have a wonderful weekend. The sun's out here in beautiful Fairfax, so hopefully it's out wherever you are. Thank you. Have a good weekend.
Thank you.